work, Paul Farmer has eloquently distilled the connection between social inequalities and the role of health outcomes in vulnerable populations. He and others have shown that social forces such as poverty, illiteracy, are drivers of HIV among the most at risk marginal populations. Sex workers are one of these populations. They've been central to the entirety of the HIV story for the past 30 years and continue to this day. In thinking about the nature of sex work, quite frankly, the biggest risk factor, of course, is having unprotected sex. But as Sissy relayed, there are a lot of factors there at play and shape individuals' ability to minimize risk. My client pays for me not to wear a condom. Perhaps people are thinking more about their economic needs, feeding themselves, feeding their children, maybe their drug habits, and it's much more important to earn more money in the moment than to plan for a disease 5 or 10 years off. I don't feel comfortable talking to my doctor. People are so stigmatized in the healthcare setting or in other aspects of their life. They don't talk about the fact that they're sex workers, and therefore their doctors don't talk to them appropriately about their prevention needs. So now I'm going to talk a little bit about my own work, focusing on the social economic opportunity of women involved in sex work. I want to say that the next few examples I'm giving are kind of alternative income options for sex workers, and in none of my work that I've done is the goal to get women out of sex work, but the goal is for them to have options, and often the interventions actually increase their ability to negotiate safer sex in their own lives. The year was 2007, and San Francisco had just voted to ban plastic bags, and I like bags. So we had this idea that what if we made canvas bags? It's a skill that's really useful in India, in Chennai, because there's a really big tailoring industry, and so it was something that would generalize to other things, we thought. So NIMH funded this study, very similar aims to the Jewel study. The first is to examine the feasibility. We also had to have a product that would sell enough money to cover expenses of shipping these products to the US. So it was a little bit different. Women had to, and we were interested to see if women would enjoy working in a scheme where they had no interface with the customer. And even though we would send back quotes that were translated into Tamil, it's just not the same thing. So we had 100 women who were randomized into one of two arms. The aim is to look at the feasibility of this project and also the effects of this kind of scheme on women's sexual health and economic well-being. They were randomized into one of two arms, a 4-session intervention, HIV prevention similar to what I described in Baltimore, and then 4 sessions plus 100 hours of tailoring. And the photo shows some of our products. Up on the top, this was a wine bag we actually sold at the Wine Source, a very popular messenger bag, and some totes. And these are some of the industrial sewing machines that we bought. We bought 10 new sewing machines as a part of our project. So in terms of the health outcomes, they were similar. We found, we're happy to find similar findings as we did in Jewel in this more rigorous study. Women earned an average of 33% more who were in their intervention compared to the control at 6-month follow-up. Their income from sex work was 40% less in the intervention compared to the follow-up. Their total percentage of income from sex work was less in the intervention compared to the follow-up, and they also had a significantly lower number of sexual partners. And in a multivariate model, in the presence of baseline age and household income, women in the intervention arm had an average of 2 less sex partners per month compared to those in the control arm at follow-up. So in 2008, a woman convened a meeting. It was a patient of a psychiatrist at Maryland, a colleague of mine, with the head of the needle exchange at the health department and myself. And there was a woman there who was a patient of his. She had danced on the block. She was a dentist's wife from the county who developed a fentanyl habit, and 5 years later was dancing on the block. So why exotic dance clubs? I mentioned the block. It's 1.5 blocks long. It used to be 4 blocks long back in its heyday. It's located very close to where we're sitting right now, and even closer, like 30 steps from City Hall, the Department of Housing, the Central Police Station. And oddly enough, in our recent work, the police are some of the men that the women feel most comfortable with because they walk them every night. They shut down the block when it's closed, and they walk them back to their cars. In terms of its HIV significance, it's a concentrated geographic space, so disease can spread quickly depending on the nature of the behaviors happening in that space. And also, interventions could really have go a long way because it could be targeted. We estimate just in the block, not in the broader. There are 36 exotic dance clubs, by the way, within 36 miles of the center of Baltimore City. We've worked in 26 of them. We estimate the size of the population to be around 500, and there's a high turnover in a certain segment. In both our earlier work and our current work I'm going to describe, about 20% of women last a month. 80% are there an average of 4 years. So there really is a split. And we were very interested in who stays and who leaves and why, and what they take with them when they leave. And how are you able to stay in this hard work environment? So you look at these sociodemographics, 23%, the age range, median age is 23, they're 60% African American, 91% graduated from high school. I gave this talk to Hopkins undergrads, and someone raised his hand. He's like, isn't $2,200 not very much money? And I had to explain that, in fact, $2,200 when you're doing HIV research in an urban center actually is a lot of money. So you look at these factors, and that doesn't really paint a picture of a high-risk population, but you need to look a little bit further. Meredith Riley, actually, as a nurse, funded her dissertation to look at this notion of stability and vulnerability. So 44% of the women reported that they had moved 2 or more times in the past 6 months. Over a third had been arrested, a lot of opioid because pills as well, crack and cocaine use. 34% reported ever selling sex, and unbelievable rates of childhood sexual violence and current intimate partner violence. Michelle Decker is working on an analysis on that. And because we were interested in the environment, we looked to see a lot of this, the drugs and selling sex was initiated in that space of the clubs. And these are women who had worked an average of 3 months in these environments. Women's vulnerability is escalated, while at the same time, stability provided by employment and education decreases precipitously. The longer you stay, the harder it is to leave. This points really to the primacy of interventions that target these environments, and not just the dancers that work within them to maximize effectiveness. In looking at the current constellation of risks, 60% of women reported one of the 4 risks that are listed above. So we actually were really surprised. 40% of women didn't report selling sex, they had stable housing, they didn't use hard drugs, and they hadn't experienced interpersonal violence currently. But of these women, the 60%, 68% have moved 2 or more times in the past 6 months. 44% reported sex work ever. 42% reported opioid, crack, or cocaine use. And 44% reported current interpartner violence. So this really speaks to, and almost 10% reported all of these factors. So this speaks to the complexity and co-occurrence of factors that need to be addressed in interventions that target this population.